Thank you, Prof. Kwan and Dr. Han. We shall now continue with the second part of the talk. We have two speakers. Dr. Nurul Adibah Abdul Rahman will present a case of giant cell arteritis, followed by some discussion by Prof. Dr. Noliza Khalidin, who is our pediatric ophthalmologist in our department in PPUM. Without further ado, Prof. Liza.
Assalamualaikum and very good morning everyone. I'm Nurul Adibah from the Department of Ophthalmology. I'd like to share with you a case on giant. Let us begin with this case of 85-year-old gentleman who came with a sick complaint of painless blurring of vision at 5:30 in the morning on 11 April 2022. However, the patient did not take any treatment and went for his regular hemodialysis at outside PhD center, and clean vision improved. However, during the hemodialysis, he became hypertensive and was referred to emergency department immediately. In emergency department, he was then referred to us ophthalmology department due to the unresolved blurring of visions. Upon further questioning from the patients, the left eye was having a blurring of vision since 3 days ago. He added that he also had history of visiting to emergency department a week ago due to jaw claudications and temporal facial pain. He also stated that he had intermittent headache. He was referred to the dental team and was treated as a bilateral temporomandibular neuralgia with nausea. Otherwise, no eye redness, no headache or vomiting, no diplopia, no body weakness, no history of head trauma, no constitutional symptoms, no residual weakness, facial truth of any speech. Well, upon examinations, the left optic nerve function was affected. However, other cranial nerves were all inside with good extraocular muscle movement bilateral eyes. The right eye visual acuity was measured as 621, while the left eye was only managed for perception of sight with positive relative apparent pupillary defect or RAPD. Otherwise, there was no sign of inflammation in both artery segments. Okay, can you see the picture? This picture shows the posterior segment of the left eye. We can see this is the optic disc, which is pale and swollen. However, the retina is normal with macula flat, and also the bezels are all normal. The posterior segment of the right eye was unremarkable. Bilaterally, if you can observe from the temporal side of the patient left and right, you can see there's a prominent, beaded, and firm temporal vessels. Therefore, during that time, the diagnosis was left arthritic anterior ischemic optic neuropathy, or in short, AION. Some lab parameters were taken, and the CRP and TSR were both showed significant increase in number. The CT brain was also done for this patient to rule out any intracranial pathology. However, he was reported with only multifocal infarct with no signs of acute intracranial bleed or infarct. Subsequently, the patient was admitted into our ward and was started on high dose of steroid for IV methylprednisolone 250 mg to IV for 3 days. Then changed to the oral prednisolone milligram once a day for 2 weeks and was tapered 10 milligram weekly. He was also referred to the classification team for further evaluation for the temporal artery biopsy. Now, the histopathology report on the left eye temporal biopsy, which was done on the 19th of April, shows focal inflammations of lymphocytic and histiocytic infiltrations with multinucleated giant cells. You can see from the black arrow there. This shows clear of multinucleated giant cell, which confirming the diagnosis of the giant cell arthritis in this period.
Thank you, Adibah. Assalamu alaikum and good morning. What I want to share today is not rocket science, but a very important aspect of patient care that we sometimes miss. Sudden loss of vision is not common, but having said so, it's not rare either. It is very important that we are aware of the various causes of sudden loss of vision, as most are treatable. Most of us know the common causes of sudden loss of vision, such as acute glaucoma or retinal detachment, but there are other causes, and any acute pathology that involves the visual axis from the cornea, anterior chamber, lens, vitreous, retina, the optic nerve, and also the visual pathway can lead to sudden loss of vision. So today what we're going to do is that we're going to look at ischemic anterior optic neuropathy as a cause of sudden loss of vision. So this picture shows the blood supply of the optic nerve. It originates from the internal carotid artery, which gives off the branch of ophthalmic artery to posterior ciliary artery and eventually short posterior ciliary artery. So any disruption of blood flow via the posterior ciliary artery will cause anterior ischemic optic neuropathy, which will give rise to signs such as optic disc edema. Blood flow that is disrupted prior to short posterior ciliary artery will cause posterior ischemic optic neuropathy, and it does not give rise to optic disc edema. In anterior ischemic optic neuropathy, vision loss is usually sudden or it develops over a few days at most and is commonly unilateral, although the second eye may be involved later, especially so in the arteritic type of anterior ischemic optic neuropathy. Now, the vision loss is usually permanent, but if recovery is to occur, it usually occur within the first few weeks or months. AION or anterior ischemic optic neuropathy can be divided into non-arteritic AION or arteritic AION. Non-arteritic ION ischemic optic neuropathy affects about 2 to 10% per 100 individuals in the United States. And it is the most common cause of acute neuropathy in the elderly. Now, the cause of AION is unknown, is idiopathic. It is postulated that atherosclerosis may be the underlying cause of non-arteritic ION. However, it has been proven that it is strongly associated with diseases such as diabetes, hypertension, or sleep apnea. Unfortunately, there's no effective treatment for non-arteritic ION, and usually patient will have permanent vision loss. Arteritic anterior ischemic optic neuropathy is also known as giant cell arteritis or temporal arteritis, and it was described by Ali ibn Isa as far back as the year 940 after Christ. And it affects about 0.36% per 100,000 population. And this is much less compared to non-arteritic AION. But unlike the non-arteritic AION, giant cell arteritis affects the GCA, affects the arterial vascular supply of many organs, and it has a higher incidence of death and morbidity compared to general population. The pathogenesis of giant cell arteritis is incompletely understood. It is more common in Caucasians compared to Asians. And it is a chronic inflammatory disease that involves the large and medium-sized arteries. As Adiba has mentioned earlier, there are infiltrations of lymphocytes and macrophages, which eventually undergo granulomatous organization and formation of multinucleated giant cells, which is the hallmark of giant cell arteritis. The early manifestation of arteritic AION or giant cell arteritis includes malaise, weight loss, fever, vague abdominal pain, and also anorexia. And later, patient will develop headache, scalp tenderness, jaw claudication, as per our patient who actually presented to ED 1 week prior to sudden loss of vision, complaining of jaw claudication and headache. However, he was missed and referred to dental instead. Adiba has earlier presented on the management of the patient, we did a temporal artery biopsy, and we were lucky that we saw the multinucleated giant cells, because we know that GCA can present with skip lesions, and therefore biopsy may be negative. It's important that we manage this patient with the rheumatologist. The key to treatment is to control the inflammation with high-dose steroids. So the patient was started on IV methylprednisolone. Now, steroid use has been used for GCA as far back as in 1932, and the length or duration of the steroid use is depends on the level of CRP, the C-reactive protein, and the ESR, and steroids are tapered accordingly. In patients on long-term steroids, other options are the monoclonal antibody and also the anti-metabolite. Vision loss in giant cell arthritis is reversible if it is treated within 24 hours of sudden onset of vision loss. However, if it is delayed more than 48 hours, the vision loss will most likely be permanent. Why is it important that we recognize this disease, giant cell arthritis? It is because it is associated with higher morbidity if left untreated. There's an increased risk of involvement of large vessels, causing myocardial infarction, cerebrovascular accidents, and late abdominal aortic aneurysm. And as we know, this patient in the CT scan had shown multiple old infarcts that can be attributed to giant cell arthritis. Now, the risk of second eye vision loss is also high, in which 50% of patients with GCA, if left untreated, will develop bilateral vision loss. Now, our patient was on tapering oral steroids when he suddenly developed acute pulmonary edema, secondary to maybe cardiomyopathy, but he succumbed to hospital-acquired pneumonia and passed away about 1 month after the onset of sudden loss of vision. Thank you very much for joining us this morning.
Thank you, Prof. Liza, for this interesting case. Do we have any questions from the audience? I'm opening both the chat group and also the Q&A group in case we miss any questions. So far, not yet. GCA is quite common in the Western population, I believe, and it's not as common in our part of the world. Is there any genetic basis for this?
The pathogenesis is basically unclear, but you are right. It is more common in the Caucasians, in the Europeans, and also in United States, but Asians are much less. So that's why we were, I guess, a lot of us are not aware because we don't see it commonly in our side of the world, and therefore he was missed and referred to dental instead.
Yeah, and the treatment, if the patient had lived longer, the treatment with steroids, it is usually lifetime. Do you know whether is it actually possible to taper down the steroids eventually?
It depends on the C-reactive protein and also the ESR. So as long as there are signs of inflammation, they have to be on steroids. So it can be long-term steroids. That's the steroid sparing agents that were suggested in the presentation. This patient actually passed away quite soon after the presentation of sudden loss of vision. He was still on tapering steroids when he passed on. We're not sure whether it is associated with the GCA or not, but he also has a lot of morbidities. He has end-stage renal failure and also on dialysis. So that multifactorial.
And we're also mentioning about it was lucky that we were actually able to get the HPE.
Because giant cell arthritis usually presents with skip lesion. So a negative biopsy doesn't mean that a patient doesn't have giant cell arthritis, because you could miss the skip lesion. That's why some physicians actually advocate to do bilateral temporal artery biopsy instead of just one side. So if one side is actually negative, but clinically is very suggestive of giant cell arthritis, then you should attempt to do biopsy on the other side in order to clinch the diagnosis.
And last question from me is usually, when we have a case like this, we know that we need to start steroids rather urgently. But do you think this would lessen the yield of getting a positive biopsy? That we, because we can't really schedule the patient biopsy immediately.
Correct. As long as you do the biopsy quite early on, after starting the steroids, the changes would not have disappeared. But if you wait till later, or if patient is misdiagnosed and steroids were started, and eventually months later you decide to do the biopsy, it may be negative. Yeah. So we were lucky that we got the histopathology result. I guess lucky in the sense that academically we know that he has giant cell arthritis, but in the end, he succumbed to his illness and passed on about a month after the onset of the sudden loss of vision. His vision never recovered. He presented with perception of light, and it persisted even with methylprednisolone. But our aim for treatment is not for so much for the vision that is lost, but for further complication, systemic and also ocular complication.
All right. Are there any further questions? None in the chat group. We have still about 15 minutes more to kill, but is there anything else you'd like to add, Prof. Liza, before we end the session?
I guess our take-home message here is that what the brain doesn't know, the eye doesn't see. So even though it is very rare, it is something that we should be aware of, because it has a long-term implication to the patient's morbidity and also mortality.
True. And I think also because it is, it happens in elderly patients who may not even complain of the vision loss. Oh, Prof. YK Chan has a question. How many days delay happened before the patient had his definitive treatment?
He presented to ED about 9 days before we made the diagnosis, when he was referred to dental. But when we took the history, actually, he had intermittent vision loss about 3 weeks prior. So in arthritic AION, entry ischemic optic neuropathy, the vision can fluctuate in the initial stage as the inflammation fluctuates. But unlike non-arthritic, which is a sudden loss of vision, which is permanent. So it's about 9 days. And he presented to ED before he presented to ED again with a sudden loss of vision. Yeah. The sudden loss of vision, the first time that he had it was when he woke up in the morning at about 5:30. He felt that his vision, in his left vision was affected, but he didn't pay attention to it. And then he went for his hemodialysis, and he had, and with hemodialysis, he feels better. But I think the next day he had a total loss of vision, projection of light. And that's when he presented to ED.
Yeah, so Prof. YK mentioned that if this was an emergency, it was a long delay. What are your comments?
What the brain doesn't know, the eye doesn't see. So knowledge is important. That's the take-home message here.
But I think largely for GCA, again, as Prof. Liza, you mentioned that the main objective is to save the other eye, save the sight from the other eye, because the eye that has been affected, usually we can't save.
True, very true.
and also morbidity, because it affects the large and medium-sized vessels. So they can get stroke, they can get myocardial infarction, and also late complication, they can get abdominal aorta dissection, aneurysm.
Also, I think another take-home message from this case is that it is very important for us to know how to elicit the Marcus Gunn pupil or the relative afferent pupillary defect. This is to really show or, prove, show evidence that the optic nerve is involved. And once the optic nerve is involved, it is an emergency no matter what.
Yes, correct.
Okay. Yes, Prof. YK says it shows that we must integrate all our symptoms and signs properly no matter which discipline we are in. Very, very true. And hence, the presentation of this case to say that it is actually a systemic disease. Okay, I think since there are no more questions, thank you very much for a very comprehensive presentation and a very interactive audience. Thank you all. Have a good day today.